everyone, and welcome to our webinar on the Discharge to Assess Process and Digital Solutions webinar. My name is Alizé McClurg. I am a social research specialist at Connected Places Catapult, and today we will be summarizing a project funded by an Innovate UK SMART grant looking at the NHS Discharge to Assess process. Just some housekeeping stuff before we get on with our agenda. Please use the Q&A function for any questions that you have as the webinar goes on. Your mic will be muted throughout the webinar, so we will read all the questions out at the end to the panelists to answer. And the recording and the slides will be shared after the webinar, so you will have access to everything that we discussed today. And yeah, please use the Q&A function as opposed to the chat function for any of your questions. And we can get started. Next slide, please. So yes, welcome. And today the objectives of the webinar are to discuss the discharge to assess process and how AI-based technology can help speed up discharge and improve clinician and patient experiences and outcomes. And specifically, we will be sharing findings from deploying an AI-based technology in the homes of patients who have gone through D2A, discharge to assess. Next slide, please. We have a great set of speakers today that will present the project and the outcomes of the trial. So first, I will introduce the project and discuss the challenge research that we at Connected Places Catapult did. And then Richard Wong, who is a clinical advisor from Willows Health, will give a clinician's perspective of the challenges with D2A. We will then have Clive Flashman, who is a MyCare strategy advisor, present on an AI-based technology that was deployed as part of this project. And then we will hear from Richard, Adriano Malouf, and Bertha Ochieng from De Montfort University to report the outcomes of the trials. And then we will finish with a Q&A session. And as I said, please feel free to add questions in the Q&A section throughout the presentation, and we will get to them at the end and then have closing remarks. Next slide, please. Thank you. So this webinar will present on a 2-year project from an Innovate UK SMART grant. SMART grants are designed to support SMEs, so that's small and medium-sized enterprises, and their partners to develop disruptive innovations. This project is specifically working to improve the discharge to assess process, which we will refer to as D2A. And we did this through deploying and refining an AI-based technology in patient homes. We have great partners on this project. So first, Connected Places Catapult, which is where I work, is the UK's innovation accelerator for cities, transport, and place leadership. And we were involved in the user research and market analysis part of this project. MyCare is a UK health and well-being technology, small and medium-sized enterprise, and they're focused on adaptive geriatric care and falls prevention. And they were the developers of the technology that were deployed in this project. We then have De Montfort University, who brings their expertise on clinical science and researching the use of AI technologies, and they were involved in the evaluation of the trial of MyCare's technology with patients. We also have Willows Health, who is a delivery partner and is the largest primary care organization in Leicestershire, serving over 44,000 patients across 9 healthcare sites. And they were the on-the-ground partners of this project to understand the frontline patient care works, including the clinician experience. And last but not least, we have the Leicestershire County Council, who participated in technical user design workshops, which was led by MyCare. And their input on the user requirements for how to use the technology helped to develop the bespoke solution, including having D2A specific patient reports and a tailored dashboard. Next slide, please. Thank you. So just to set the context a bit of, what is discharge to assess? So this quote is from 2013, and it describes some of the challenges with discharge at the time. So discharge to assess model is built on the principle that patients should not stay in hospital for any longer than they need to, and instead should have the opportunity to recover and rehabilitate at home before their long-term health and care needs are assessed and agreed. So D2A, the concept was first developed in 2013 by the Sheffield Teaching Hospital NHS Foundation Trust. And the team tested a new discharge process for frail and older patients with the aim of improving patient flow and getting people back home as soon as they're medically fit and to have their support needs assessed at home rather than in the hospital. And the reason for this would be to reduce the length of stay in hospital and improve the quality of assessment. So the D2A model in this situation resulted in positive outcomes, with a 34% increase in patients being discharged on the day of their admission or the following day, with no increase in the proportion of patients readmitted to hospital. And so this is quite significant because long hospital stays can lead to an increased risk of mental and physical deconditioning. And they also found that it improved the quality of assessment of the patient and improved the patient experience. And so since 2016, the D2A model has been promoted as good practice by NHS England. Next slide, please. So there are 4 main pathways within D2A. This project specifically focuses on pathway 1, which is when patients return home with new additional or restart a package of support from health and social care. And about 45% of people go down this pathway. Pathway 0 is when people are discharged home and don't have additional social care support. And then pathway 2 or 3 is when patients go to a different facility for a bit more intensive support. But as I said, this project really focuses on deploying technology for patients who are going through pathway 1. Next slide, please. Now, as I mentioned, Connected Places Catapult was involved in the challenge research of this project. So the first stage of the challenge research was really to understand the D2A model and the touch points from the patient perspective. So this is kind of a busy slide, but I'll talk through it a little bit. The goal of doing this kind of touch point and journey mapping is to really understand who is involved at what stage of the discharge process, and therefore understanding where technology could help enhance the model. So there are 3 main stages. So the green on the very left is pre-admission. So this is before the patient arrives on the ward. Then we have during hospital stay, which is the blue. So this is when the clinical team assesses the patient and then makes a decision about which pathway they would go down. So they're just the pathways that I presented just before. And then lastly, the orange is about post-discharge. So this is when the patient returns home or to a facility, depending on the pathway that they've been discharged on, and await further assessment and care. And so as you can see, I won't go into detail, but there are a lot of different stakeholders and different teams involved at the various stages of the discharge process. Next slide, please. So now we will go on to the challenge research, which will be presented by myself and then Dr. Richard Wonk. You can go to the next slide, please. So as I said, we did challenge research. So part of that was creating a stakeholder journey map, which one of the outputs of that was what I just presented. So looking at the different touch points from the patient perspective. And we also really wanted to understand just the experiences of the D2A model from both the patient and healthcare professional perspective. And so we did this through desk research, as well as interviews with healthcare professionals and patients. And within healthcare professionals, that included discharge teams, clinicians, patients, and NHS commissioning bodies. And so I will now report on some of the challenges that were uncovered through our research per stage of discharge. Thanks. We can go to the next slide, please. Thank you. So first, for pre-admission, we found that there can be complexity involved in navigating and accessing social care services, as well as delays in receiving care, which could potentially lead to hospital admissions. So through our research, we found that older persons who may be struggling to look after themselves at home that can result in their family or support system looking into sources for having additional package of care or home help. This can be difficult to navigate just because of the complexity and the differences in the services offered, and sometimes can have a lack of availability or unaffordability for people. And so without being able to access these services, sometimes patients and older people can come into kind of a crisis point, which is what can result with them going into hospital as their first point of kind of contact. Next slide, please. There are several challenges that came out during the hospital stay, but I will just talk on the first 3. So the first is handover between clinical and social care teams. And so through the interviews that we did with the different teams, we found that sometimes clinicians can face challenges in communicating with social care. We found that social care didn't have access to some of their systems, including System 1. And this meant that communication was done through written notes by the clinician over the phone or in person on the ward. We also found that geographical challenges for social care teams based in rural areas meant that coming into the ward was deemed time-consuming, and therefore some of the communication had to be done over the phone, and some information could be missed. And we also found that social care teams are extremely busy and sometimes lacked resource availability. And so sometimes they would receive unrealistic care packages from the clinical teams just because they may not have had an understanding of what can actually be delivered on the ground and depending on the patient's needs. Second, we had integration of digital systems. And so we found that each healthcare authority that supports patients on the D2A journey uses its own digital systems. These systems are crucial because they maintain patient profiles and records. However, sometimes poor communication between the systems can mean that there's frictions within the process. For example, systems may not provide an updated profile of a patient in a timely manner, which can slow down the process. And the greatest need from this was having awareness of the patient and their well-being. And one of the clinicians that we interviewed mentioned that while there are already enough systems, they still welcomed having another system if it added to the holistic patient view. And then lastly, the other challenge I will talk about during hospital stay was just deconditioning of patients. So patients can become deconditioned with more time spent on the ward and in a hospital bed, which can increase their frailness. This can result in the need to change the care package before discharge if it's deemed that the patient has developed additional needs while they're in the hospital. And additionally, deconditioning in the hospital can lead the patient to be frail when discharged and potentially increase their chances of falling over whilst in home, which can then lead to being readmitted. Next slide, please. The last challenge theme I'll present on is during the post-discharge phase. So we found that sometimes a lack of clear, personalized, and proactive communication can lead to patients being readmitted to the hospital. So several clinicians highlighted the importance of communication with the patient and their caregivers in order to equip them with a full understanding of what they needed to do when they go home. So this could be, for example, information on changes in medication, as well as care planning should any medical issues reoccur while at home. And we found that giving patients and carers clear and detailed advice that they can access at any time post-discharge is vital to ensuring that patients aren't readmitted to hospital. And then lastly, capturing a holistic picture of patient well-being. Healthcare professionals value the experience of seeing patients in their homes. However, their assessments were often limited in time, making it challenging to get a holistic picture of the patient's well-being. And so before I pass on to Richard to talk from the clinical perspective, I just wanted to say that the challenges that we uncovered through this research was really to try to understand where can technology, and specifically AI-based technology, can help intervene on some of these challenges and pain points. So Richard, up to you now. Thank you.
Thank you, Alize. So I'm Richard Wong. I'm the chief investigator for this study, but I'm also a consultant geriatrician by trade. So I'm going to address the challenges of complex discharges from hospital, and perhaps the image of riding off into the sunset is the wrong image to conjure up, but certainly how we can keep these individuals, once they leave hospital, keep them cared for and settled when they return home. And the background to this healthcare challenge is not just the aging population, but the increasing amount of people who become frail with older age. And just for clarity, I'm going to explain what I mean by medical frailty. And that's people who have become weaker and less stable through cumulative social and healthcare insults. This is often associated with multimorbidity, but not always. And as a result, such individuals have little reserve, so they may decline precipitously with fairly modest insults, and they'll often take a long time to improve, often not completely recovering. So that's the context of the patients we're dealing with. And of the 4 discharge pathways that Alize summarized for you earlier, about looking at local and national data, about 10 to 25% of people being discharged from hospitals would have some complexity and go under pathways 1 to 3, which is some form of supported discharge on the D2A process. Now, pathways 2 and 3, in some ways, for healthcare workers are relatively more straightforward, often more straightforward for relatives of these older patients as well, because that's where an individual is discharged to either a residential care facility or a long-term care facility, community hospital of some sort. So we know that there's wraparound care, there's night care, and there's more or less a continuous care presence around. What is more tricky and what people are uncomfortable with very often are the discharges home on pathway 1. But we know that we are here trying to balance here patient autonomy and patient independence compared to their safety. And that's a delicate balance sometimes. So ensuring that they can manage satisfactorily overnight might be difficult, especially with more people living alone or families who are not living near them. And these are some of the barriers sometimes in terms of people being discharged home to their own homes. And even if they do accept domiciliary care, there's no guarantee this will be maintained in the long term, because once the funding runs out for the free assessment period, it will be means tested, and they may be self-funding or part funding and decide that they do not want to maintain some of these services and payments. And layered on top of all of this is the inherent instability of such individuals. I've mentioned already, relatively modest insults can end up destabilizing them. So just extremes of climate, not drinking enough, getting constipated, having a minor infection, and these may result in major swings in their health condition. And when things do not go according to plan and they are readmitted to hospital, I think there's a tendency to pejoratively term these failed discharges. I don't think that's a helpful term. It's not a term that I use. There can be many explanations for this, ranging from the individual valuing their autonomy over the accepted risks. It may be that insufficient information was provided to equip the care in the first place for discharge. And there may, of course, be genuine under-provision of care and medical instability. But again, touching on what Alize mentioned just now, it's often not 100% clear when people are readmitted to hospital what the triggers were. We often lack that fly on the wall insight, or certainly we lack that sort of detail of information about what actually went wrong, what they struggled with, what they got on well with once they returned home. I've mentioned the potential under provision of social care, and that can be a genuine issue, but we also have to deal with the fact that sometimes there is over provision of care. That may be at cost to the local authority and also to the user, not just in terms of how much they're paying for it, but also through reducing their independence. And there may be reasons for over provision of care, such as family anxiety as to whether or not, if we cut off one of the care calls, will they really manage? If we don't prompt that medication, will they really take their medication? And sometimes care is provided for relatively modest indications, such as prompting of medication, when perhaps there could be other means of providing this. So I hope that's just summarised some of the key common issues we experience. I'm going to hand over now to Clive Flashman from MyCare, who will take us through how technology can potentially support some of these issues.
Thanks very much, Richard. Okay, so if you move to the next slide, please. So given what we know about the way that the elective backlog happens and how it continues, the key problem that has to be addressed is how we can move people who are medically fit for discharge out of hospital sooner. MyCare provides a supported step-down care option for Pathway 1 for people who can be helped to live independently in their own home. I'll run through how it does this from the point that the person is about to be discharged from hospital. Firstly, the discharge team determine that the individual is suitable for the MyCare solution and allocate this to them electronically in the discharge system itself. They can be helped to get home through patient transport and even have food waiting for them at home if they aren't able to go shopping themselves when they return. Very soon after that, a field services team member used to working with vulnerable people will come to their home, set up the equipment, show them how to use it, and talk them through how to take readings with their medical devices, and of course, how to interact with Monica. If they don't already have broadband access at home, then a USB dongle can be plugged into the Cube, Monica, and this will provide it. In this way, no potential user is digitally excluded from the service. Monica can interact fully with the user, suggesting tips and ways of managing their health. It's an AI-driven digital health coach that bases its advice on the data that's being collected, both on the person's vital signs and on their activities in their own home. Whenever the individual uses a medical measurement device, Monica will voice the reading, which takes away a lot of the anxiety that many older people have around using these small medical devices. This data is also displayed in an app that carers and family members can see and shares smart insights derived from bringing together all of the data collected about the home user so far. These insights can also be relayed to the user intermittently via Monica. Monica feeds all of this data into the assessment process and enables service providers from both healthcare and local government to access the same information. This facilitates closer multidisciplinary team working and helps to ensure that the completed assessment has input from all the relevant parties and is as accurate as possible. Next slide, please. So what is Monica, or who is Monica? It's an AI-driven voice assistant that is also a home hub, controlling and bringing together all of the data that the home and medical devices collect. It brings this data together to suggest things to the user, such as the need to hydrate more frequently so that they avoid being readmitted to hospital with a UTI. As well as collecting data, Monica can provide useful information back to people. It can be loaded with certain health apps that can then support specific conditions and help the person deal with issues such as poor sleeping patterns. Monica can help to reduce social isolation too. As well as conversing with the home user, it can be used as a communication channel by others, such as community nurses. In the future, we also hope to load it with a local directory of services so that it can recommend local community activities, much like a social prescriber would do. Imagine the user saying, "Monica, what local activities are on this week near me?" and getting details of art classes, reminiscence groups, etc. As well as the micro interactions such as medication reminders, Monica can help to smooth patient flow along a care pathway, reminding people about follow-up appointments, checking in on care plan goals, and more. Next slide, please. I know this is quite a busy slide, but I was trying to show you some of the key benefits that can be gained by using Monica and the MyCare solution. The potential benefits of using the MyCare system include both cashable or financial opportunities, as well as softer benefits for the individual at home and those involved in their care and assessment. Financially, by providing supported step-down care, we can help to reduce the average length of stay in hospital, helping to chip away faster at the elective backlog. By continuously monitoring the individual's health and wellness, we can also help to reduce readmissions and their emergency visits. If the person does have to be readmitted, then the healthcare team will have access to up-to-date information collected over the last few days or weeks, which means that care support can be better targeted and more effective, thus decreasing the length of stay for that episode of care too. Through the use of AI tools, data can be analysed intelligently, generating more meaningful insights to trigger actions by carers and the individual themselves. This can potentially extend the amount of time they are at home rather than put into a care home, a significant saving for councils that have to fund these care home places. Through the interactions that Monica has with the individual, it can detect what elements of the initial care package, including assistive technologies, are actually being used. Aligning the assessment and reablement processes through a single digital support tool also helps to bring clarity to both teams. Ascertaining what isn't of use to the person means that follow-up care packages can be better targeted and possibly even cheaper. Overprescribing of care packages is a known issue, and Monica can help to bring these costs down. Through the support and interaction that Monica provides, we've established that people at home require fewer home-based welfare checks and less overnight support. Reducing these face-to-face visits also saves a significant amount of money per person. The solution provides meaningful care interactions for both service users and health and care staff, improving access to care services and making the sharing of information simpler. By doing all of this, it generates more positive outcomes for vulnerable citizens and helps to reduce the administrative burden for staff. Thanks very much, and next speaker, please.
Thank you, Clive. So we're going to present now on the some of the preliminary outcomes from the D2A Smart Incubator study. Next slide, please. I'm going to quickly take you through some of the initial findings from the study, and before that, just the process of recruitment. And then I'm going to hand over to my colleagues from De Montfort University to share some of the interview methodology and the preliminary outcomes from those interviews. Firstly, just to confirm, this was a study testing the use of smart technology in supporting Pathway 1 discharge to assess from hospital. So patients going back home with some level of domiciliary support. And the aim was to see it was a proof of concept study, testing whether some of these aspirations of application of the technology would work, could work, and would be acceptable to users. In the interest of time, I'm just going to I'm not going to go through all the criteria for inclusion and exclusion, but first I'm going to say a big thank you to University Hospitals of Leicester and for the discharge teams and therapy teams, and for the backing of our chief exec and the chief medical officer of the ICB who've given their backing for this. So without them, none of this would have been possible. Now, this study has been NHS ethics approved, and we recruited patients who are over 65 or 65 and over, who are predominantly living alone and able to communicate in English and had capacity to consent to participation in the study. And these had to be people who are not averse to using technology at home. So those were the very broad inclusion criteria. And over a 2-month period, we approached 152 individuals, of whom 27 people signed up for the trial. Now, once these people signed up, the process, as Clive has already outlined, was an installation which took place via the Willows Health Clinical Delivery Team, and the installation of hardware could include the core components, that's the Monica Cube, plus a range of room sensors and a wearable device that could track activity and some basic physiological measurements. And as indicated by clinicians, additional components could be requested, such as an electronic dosette box sensor or sensors, formal physiological measurement devices such as pulse oximeter, digital thermometer, and a blood pressure monitoring device. We ensured those people who did not have a broadband were not excluded, and as Clive mentioned, roaming dongles were supplied for such individuals. And they had the device for 4 weeks as a minimum, which is the average time for a D2A assessment process, but all users were given the option of retaining the device free of charge for their own use after the trial ended. Next slide, please. So what have we experienced with the technology, and what has the technology been able to demonstrate to us so far? I think it's important to highlight this is really testing of a novel technology in a new and challenging care setting. I'm not aware of anything similar that's been tried in this context before. When I say novel technology, some of the core components of Monica are established and already commercially available. Added functionality has been added, and obviously with this care setting and the challenges that provides, that has been an entirely new paradigm. So I'm going to start with some figures first to orientate us as to the scope of the project. And we look at the bottom set of numbers. So we assessed 27 patients over 2 months. The numbers are certainly smaller than we would have liked, and it reflects the fact that we had a limited time to carry out patient recruitment because of attaining NHS ethics approval. But I would stress this has met the stringent or the stringent assessment for NHS ethics, but that did leave us with less time in order to carry out recruitment. Of those 27 patients, we analysed over 1,200 voice interactions with Monica, and 2/3 of these were initiated by the user themselves, as opposed to Monica posing the initial question. We also looked at 18 novel voice biomarkers. I'll mention these now, but I'm not going to go into any more detail about these. This is still very much a work in progress to see whether we can look at various aspects of voice intonation, meter of speech, to see whether these can give us some lead on mood changes and correlate that with other methods by which we're trying to assess mental health changes. So, as I said, this is a proof of concept study. It's also a test of user acceptability. So was Monica able to monitor and track trends for users? I'm going to share some of what we actually found. So the left-hand infographic shows you a dashboard report for a user and what that might typically look like. And where requested, relatives could have access to this, otherwise it was being monitored by clinicians at Willows Health. And what we found is that, tracking soft signs was probably one of the most effective things it could carry out. These are things such as general levels of activity and step count, movement between rooms, bathroom and toilet use, and particularly nighttime activity and sleep. Physiological monitoring was a bit more challenging because of non-engagement with either the wearable device or with actually measuring their observations on the supplied devices. But that may not be something that is too unfamiliar in this patient population. I'm going to share 4 snapshot stories which give us some insights into what this might achieve. And I'm going to just put your attention onto the right-hand infographic, which is the ability of the device to give some smart insights depending on analysis of some of the trends. So first of all, one of the stories I'm going to share is an individual who had a fall, and he wasn't wearing a wearable device or a pendant alarm at any stage during this. He fell and he cried, "Help, Monica." And Monica was able to then make an urgent phone call to his daughter, who was the next of kin contact linked to the device. She could then alert for the ambulance to attend, and he was assessed and maintained at home. So that was the one example of where people are not always compliant with a wearable. We have access to voice activation for alerts. The second story regards a user who had started to express suicidal thoughts, and Monica had been asking them generally how they'd been feeling. Suicidal thoughts had been expressed. This was an individual with some background of mental health problems in the past, and through the alert, I was able to contact the patient's own GP to go around and attend to the patient and just do a safety check. One of the third insight that we had was similar to the infographic on the right. and an individual who the device was reporting prolonged time in the bathroom, and this individual ended up having, it was due to rectal bleeding, and that resulted in the patient being readmitted to hospital. And finally, this is something we're still interrogating and learning from. There was one user who had reported to their doctor that they were feeling dizzy and they had a lowish blood pressure. As a result, the doctor had stopped the diuretics, their water tablets. And as a result of this, we noticed a trend in reduced activity levels and transition between rooms, because essentially the person was becoming more breathless as their heart failure was getting worse again. So those are just 4 insights into how that we've been able to see in this at this stage of our trial. The middle infographic on the slide shows you what an end of assessment summary report might look like and could be made available for the use of social services or care coordinators who are trying to commission ongoing care for an individual. I'm going to hand over at this stage to my colleague Adriana Malouf to just take you through some of the methodology. Next slide, please.
Oh, hello. Thank you, Richard. Thank you. My name is Adriano. I work at the Montfort University as a research assistant alongside with Professor Bertha, who oversees the Smart Incubator Studies, and Dr. Richard Wong as well. So my PhD is in health sciences with focus on social aspects and the care of older people. So I'm responsible for the qualitative component of this project by collecting and analyzing interviews. So we are employing semi-structured interviews, involve all stakeholders in the discharge to assess process. So we are interviewing all the patients, then their next of kin, health and social services professionals. We are employing an interpretive approach and thematic analysis to generate the results. But at the moment, we're still collecting data, and the analysis is in the early stages. So, but nevertheless, we are able to present the preliminary findings or initial insights, is how it's named, grounded on the data regarding how participants experience and use the Monica MyCare device. Okay, next slide, please. So the data so far, the data so far shows that some older patients use Monica as a companion aid. The voice technology seems to be key to make this connect with the patients to communicate. And we noticed that Monica was especially important and useful for those patients who are the most isolated. So this quote here from patient 30 is a person who doesn't have a family around. He have just a few friends. Who as well lives a bit away from him, and he basically relies on the neighbors to get some help. During the interview, he told me, he reported that sometimes he spent many days, perhaps even weeks, without speaking to anybody. So Monica seems to be make a difference in his life, and he found it quite useful. Okay, the next slide shows another important benefit that seems to be beneficial, is about the prompts that Monica can give to the older person. So, and that enables and reminds them to engage with healthy behaviors. And something quite important, like I reminded them about the medication. And also, when I asked to the older person whether they would act on the reminders, it seems to be they reported they did it, and after the remind from Monica, they would then act on that, take the medication, and the reminders varied a bit depending how the carer want to what the carer wants to do, remind the older person. So it was, they could create different reminders accordingly with the needs of the older person. Okay. And a third and last benefit, next slide, please. It would be that it provides Monica, by monitoring, Monica could provide some reassurance that the person was well, the older person, the older patient was well at home, to the carers or next of kin. So that seems it was across most of the carers and next of kin were quite consistent in reporting that Monica was very useful for them to provide assurance. And sometimes the carer next of kin would live quite far away, a long distance. They couldn't be daily on a daily basis to see. So the monitoring was quite useful, and most the next of kin would access the dashboard through their mobiles. So it was quite, as well, it was quite easy for them to have a look and check if the other person was doing well. They were particularly interested in looking at how the person was moving in the house, the amount of movement in the house. So that would give some assurance that the person was safe and was well. Okay, I'm gonna pass now to that. That's all the benefits as in early stages. So probably there are more things that may come up. So I'm gonna pass to Professor Bertha now. Thank you.
Thank you very much, Adriano. Hi, everyone. My name is Bertha Ochie, and I'm a professor of integrated health and social care within De Montfort University. One of the researchers in the project, working closely with Adriano, Richard, Professor Mario Gongora, and the wider team. As both Clive and Richard have alluded, given the study's uniqueness in introducing and deploying technology to enhance the D2A process, we had anticipated some challenges, and therefore we also utilized a modified action research approach, and also the co-production continued through the interviews and feedback from the older adults and their carers also. So one of the key challenges that we have identified at this stage is issues to do with connectivity, which we had anticipated also because we are working with older adults also who are residing in rural areas within Leicestershire. And we were keen to ensure that we address issues of digital poverty through digital inclusion within this target population. And dongles were deployed and used in these cases to enable the connectivity and improve that. And where issues persisted, these have also been currently being addressed. And in some instances, we also realized that some of the sensors deployed were not paired properly with the MyCube, and this too is being addressed in terms of the challenges that were identified. Next slide, please. Another key issue that we've already received feedback from the older adults and their carers are attributed to technical issues, which on review and including discussions with our MyCare colleagues have primarily been attributed to the incorrect placement of sensors. And in some cases, this could have led to Monica not detecting user presence, and therefore reminders were being undelivered. And this is a learning that is being addressed now in terms of ensuring and smoothing the D2A process and the technology that we are using in deployment. And also, for some of you who are aware about Leicester and Leicestershire, given the diversity of our patients, including patients with cognitive challenges, and some patients had difficulty pronouncing Monica's name, which could also suggest that the model requires additional training to understand various accents, speech impediments, and also pronunciation variations. And Richard had already mentioned some of these. So some of these technical issues are also being addressed in terms of refining the model going forward. And finally, the other challenge that we have uncovered so far, next slide, please, is relation to engagement with the users. Some participants who are technological averse or had neurodegenerative problems like dementia were actually unwilling to respond to her prompts, because one of the key strengths of Monica is that it encourages user engagement, but the prompt has got to come from the individual themselves. And in some instances, Monica attempted to engagement with patients, and in those cases, patients were busy. When we explored this, we realized examples that were given was that there could be some background noise, such as the television is on or the radio and being on, which could further complicate the process, leading to errors in interpreting user engagement. So that is also being addressed now in terms of refining some of those challenges. So broadly, those are the three key challenges that we've identified so far, and the research is still ongoing, and these are just the initial insight that we wanted to share with you. I'll pass you over to Alicia. Thank you.
Thank you, Bertha. Thank you to all the speakers for presenting. It was, really good to just kind of see the whole life cycle of the project and certainly the outcomes of the trial. So we have a few questions in the Q&A, and I just welcome everyone, if you have any questions, to please input into the Q&A now, and we can ask the different speakers. So first, I think this will be a question to Clive, and Richard, also feel free to come in and answer as well. The question is, we know that transport to healthcare is also a significant barrier preventing people to access care. How can a technology like MyCare help on this topic beyond just reducing the number of A&E visits? So Clive, over to you, and then Richard, jump in.
Good question, thank you. And actually, we're working in Buckinghamshire at the moment with a services partner who coordinates patient transport. This is a separate organisation to the NHS itself. So they coordinate the transport to and from the hospital as the patient needs it, particularly post-discharge. And what we can do through Monica is that we can remind them about that upcoming appointment. We can tell them that the bus or taxi, whatever it is on the way. And then obviously we can also remind them if there's anything else that they need to know about transport and other services. So that combination of the logistics organisation and the digital-based reminders have proved very successful.
Thanks, Clive. Anything to add on that, Richard?
Thank you, Clive. Yeah, I would just say, in addition to Monica acting as a sort of digital concierge in that sense to kind of transport services to healthcare, you could see almost an ecosystem building up in general where digital technology integrates with other services that the ICB has set up, such as virtual wards and these sorts of community-based teams where they could be online for first responders, or linking it with urgent emergency care centres, so that some sort of provision could be brought to the individual on the basis of an alert or smart insight, rather than the person having to have a default path of going to A&E or just remaining at home with no care.
Thanks, Richard. We'll go on to our next question. So I'm just going to read it word for word. So this question is, the trust I'm working with is looking to digitize their transfer of care hub referral form. I'm super aware that by simply digitizing a rubbish piece of paper, you end up with a rubbish digital piece of paper. So this question was to myself and to Richard. Did your initial research uncover any best practice for how to approach this type of work, so digitizing forms? I can go first, Richard, and then over to you. I think we didn't really look at the kind of technical aspects or tested how you digitize these forms. Our research was more so looking at the process kind of from a holistic standpoint. So I think that we, probably don't have too much to say on this question. So Richard, over to you.
Yeah, I think it's a good question. I'm understanding that perhaps you're thinking about digitizing information for a patient leaving hospital, and that information needs to go to the transfer of care hub to commission and plan community services. So that's how I'm reading it. At the moment, that's paper-based in our organisation too. I think one of the, although we didn't approach that directly in the user-centred phase of the study, Alize mentioned about the lack of joined up information and the fact that some systems are digital and they're different digital systems, and some are paper-based and they don't all talk to each other. It may not answer your question directly, but what we have considered is that the final assessment or the reports, some of which were shown on the screenshot that I presented, could be provided in an embedded document that could link in with perhaps System 1 or whatever's local electronic system health record being used, and it might provide some degree of wraparound information that a person's level of activity in real time, what they're doing, what their basic observations look like as a baseline, could go into a record and be handed over as a bit of a transfer of care piece of information. Certainly once they are discharged back to GP's care, or if they get readmitted to hospital, the hospital would, might be able to see this potentially if it's embedded in their electronic record. They could see exactly what went on from that assessment through the digital record.
Thank you, Richard. My next question will be for Adriano and Bertha. So I'm going to just do 2 questions in one go. So the first one is, were there any issues with the wearables, for example, forgetting to wear them? And then the second is, have any users, so older adults and carers, requested to keep Monica the device? And if so, how many did from the trial group? I think Adriano and Bertha, you're probably best placed to answer those questions.
Yes, I think there was where I don't think there was people forgetting about wearing the wearable, but some people didn't like the watch, things like that. Yeah, that was a more personal choice, really. The older person sometimes would have already wears a watch, so they were very keen to having a second watch that to wear for that matter. And there are quite a good number of older patients and carers that decided to keep Monica. At least half. I don't have the numbers exactly. At a minimum, half of them decided to keep Monica because it was really useful for them.
Great, thanks, Adriana. Anything to add to that, Bertha?
Yeah, just to add that although it's in the first phase of the trial, as Adriano has indicated, nearly half of those older adults and their carers actually requested if they could keep Monica, and that's a really good in terms of the benefits that they had highlighted going forward. Yeah.
Thanks, Bertha. I think we have time for 1 or 2 more questions. So this one would be for Richard. So it is, the D2A process for older adults remains challenging across the NHS. What unique features could I highlight if I were to recommend the device to my trust? Anyone else can add in, but Richard, we can start with you. I think you're muted.
Could you just repeat the last part? What unique features
Yep, I'll just repeat it all. So the D2A process remains challenging across the NHS. What unique features could I highlight if I were to recommend the device to my trust, my NHS trust?
So what I would say is that we're still learning about the device. As I said, this research is not fully complete yet, and we're analysing outcomes and seeing what useful trends and whether the things such as voice biomarkers really help us as well. In what we do know is that tracking soft signs, it provides a useful eye on the patient. I think one of the things is particularly around sleep and knowing what individuals are doing at night time. So that, on some patient reports, it would tell us they were up 2 or 3 times and they went to the bathroom, and we'd know roughly, what they were doing, or they got up at 3 in the morning and they remained up and were just wandering around the house. So those sorts of things are quite useful and quite useful to reassure family members who think that, the night times are a particularly risky period, or perhaps when they've been on the hospital ward in that environment, they've been more prone to confusion or delirium at night time, but actually they're more settled at home. So it provides some reassurance in that sense. Beyond that, I think it's, as Bertha mentioned, action learning. We're adapting, and what features may be useful. I think we're going to find more useful features as we adapt, learn and adjust the technology to fit in with the users.
Thank you, Richard. I think that will conclude our questions. I know there's a few questions that came through the Q&A that we weren't able to answer. So when we send out the slides, we can try to answer the questions in that email. Richard, can I just turn it over to you for kind of final remarks? But yeah, just to say thank you all so much for joining this hour. Appreciate your time, and over to you, Richard.
Thank you, Alice, and thank you to all attendees today for your interest and staying with us through this webinar. I hope there's been some information there that's given you food for thought. As I said, this is a project which is still in progress, and we're learning all the time. I would encourage people to remain engaged, and if they want to explore the technology and have those conversations with MyCare and see how technology might be adapted or tested in their environment, that might be a good start. We're very much still analysing what its outcomes have been, as I said, but anything we take forward is a very new care arena, and I think whoever joins in and starts to use this kind of joins in that sort of live action research. So good luck to all of you who go on this journey, and thank you for joining.
Thank you all. Have a good day.